So there is an unfortunate lack of data when comparing Bruton's tyrosine kinase inhibitors, particularly in the first line setting. Certainly, the gold standard for comparing treatments is prospective clinical trials. And in terms of the FDA approved options, we do have that available in the relapse setting, comparing Ibrutinib to Acalabrutinib in the Elevate RR study. That study showed a non-inferior progression-free survival, which isn't surprising since these two drugs both covalently bind Bruton's tyrosine kinase at the C481S binding moiety, and that's how they ultimately, treat the CLL in terms of inhibiting tumorigenesis and leading to senescence and apoptosis. Where these two drugs differ is their off-target kinase activity, and that study did show that there were certain toxicities that were reduced in Acalabrutinib patients as compared to the Ibrutinib patients. Specifically, one of the secondary endpoints was atrial fibrillation. We do not have a similar comparison in the frontline setting, and it's not always able to be effectively done to extrapolate data prospectively in the relapse setting to frontline treatment, and that should be done with caution. There is not currently an ongoing prospective trial in the first line setting comparing Ibrutinib and Acalabrutinib, and we likely will not get this comparison prospectively. So where that leads us is needing to try to find other ways to compare these treatment options in the treatment naive CLL patient population. And so we look to leverage real world data. Also, just as a caveat, oftentimes we will see differing outcomes in real world data when comparing them to prospective studies. And that's something that's also always of interest to look at, is are we seeing these same outcomes in prospective trials as well as the real world setting, with the lack of as rigorous oversight that you get on clinical trials and rigorous follow-up. In addition to that, clinical trials often exclude many different patient populations, so you're not really getting the full CLL patient population picture when strictly looking at data from prospective studies. So we were interested in answering a question that likely is not going to ever be addressed by a prospective study, which is comparing Ibrutinib to Acalabrutinib as a first-line therapy. And in addition to that, also looking at the trends that we're seeing in the prospective Elevate RR trial in the relapse setting, are they also borne out in the real world data? And then what the specific endpoint we looked at with real world data is called time to next treatment. And it is difficult to, particularly in indolent lymphomas, get an accurate idea of progression-free survival, which is the typical primary endpoint that you see in a lot of circumstances in prospective studies in CLL. But what you can do with real-world data is look at time to next treatment, and that is a particularly valid endpoint in treating indolent lymphomas like CLL, because there is the significant number of patients that will have progression of their disease, but being that we don't treat CLL, even in the relapse setting, unless it's symptomatic, some patients can go multiple years from the point of disease progression before requiring their next line of therapy. So some have argued that time to next treatment is maybe even more a clinically meaningful endpoint to evaluate for indolent lymphomas like CLL. So we were interested in looking at that endpoint specifically with our real world data. It's also nice to be able to look at that endpoint because the prospective studies often do not look at time to next treatment as a primary or secondary endpoint. It requires a trial to be open for much longer and significantly more resources committed to look at that endpoint. So we felt like the real world data was a great opportunity to answer a question like time to next treatment when comparing Ibrutinib to Acalabrutinib in first-line CLL treatment. We used the Centris EMR support tool that leverages both electronic medical record and pharmaceutical dispensary and pharmacy fill data to assess time to next treatment in a large patient population that includes a database of 128,000 prescribers at 24 sites, including 10 NCI designated sites and 6 NCCN network members across 14 states. Out of that pool, we were able to assess approximately 710 patients that were identified as first-line Ibrutinib patients versus 373 Acalabrutinib first-line treated patients. There was a median of 17.1 months follow-up on the Ibrutinib arm versus 12.5 months on the Acalabrutinib arm. And what that showed is at 15 months that 5.9% of the patients in the Ibrutinib arm versus 7.5% of patients in the Acalabrutinib arm had to go on to a second line of treatment, and that represented an 89% difference between these two groups at that time point, favoring Ibrutinib. For the Ibrutinib arm, the mean time to next treatment was 9.2 months, and for the Acalabrutinib patients, the mean time to next treatment was 6.2 months.